تكملة للسؤال الدكتورة فايزة. Do you recommend إن شركات التأمين تعملها part of the regular examination for women who have family history إنهم يعملوا الكروموزومال test for the breast cancer? Or only when the doctor require? It cannot be a routine for people with history.
No, it's this testing is routine if there's a family history. So the insurance companies cannot deny you that test.
Okay.
If you have a family history of breast cancer, a strong family history, and you order a BRCA1 or 2 gene mutation, the insurance company cannot deny it and they'll have to pay for it.
Okay.
Insurance companies cannot discriminate on history, on family history, on pre-existing conditions, and so on. So, they can't mess with that.
Okay. Another question about the biopsy. A lot of people think if you do the biopsy, like they see a lump, they don't know if it is like cancer or not. So we want to do a biopsy. They think if it is cancer, it will spread during the biopsy itself. So is this a myth or a fact?
معناته مش هنعالج الأورام خلاص، سيبنا يا رب العالمين. معناته خلاص اروح اشتغل حاجه تانية، ابيع فلافل ولا ايه، مش عارف.
احنا لازم نوضح للناس يا دكتور عشان في ناس كتير بيخافوا.
طب يعني اذا ما اخذنا عينه كيف هنعرف انها سرطان؟ طبعا it's a myth. When you do a biopsy, 99% of the time you are not going to spread the cancer cells. You're not. It's a core. It goes directly into the tissue of the tumor and you take it. And sometimes we do an open biopsy where you cut a little bit and take it out, if it's a lymphoma, let's say. There are certain cancers that we don't like to do biopsies because you could have what we call neurotracking, and maybe it spreads a little bit, but not breast cancer. If you tell me kidney cancer, if you have a mass on the kidney, we don't do a biopsy because if it looks like a cancer, it's very specific on CT or MRI. It looks like a cancer, you have a kidney mass, you go straight to surgery. In that sense, there's no need for a biopsy because it could track the tumor, but definitely not in all the other cancers. So this is definitely out of the question.
طيب عايزين حضرتك تكلمنا على النيو تريتمنت اللي سمعنا عليها مؤخرا زي injecting chemo or radiation buds.
Injecting chemo or a?
Yeah, like chemo, very little chemo buds or radiation buds be injected to the area of the cancer. I heard some people suggested it in
not conventional chemotherapy.
Yeah. Some people suggested it with liver cancer.
The newest modality is what we call transarterial chemoembolization or transarterial radioembolization, TACE or TARE. In certain cancers, it's done very commonly in liver cancers or cancers that have liver lesions in them, like cholangiocarcinoma or let's say colon cancer that has spread to the liver, where you access the artery that feeds the liver. This is okay. It's the hepatic artery, and you block it basically. You block the blood supply to the liver.
Okay.
The liver cells will die slowly, and the cancer cells will die. Why we could do it in the liver? Because the liver is the only organ in the body that has what we call dual blood supply. The liver has blood supply from the portal vein or hepatic artery. If we block blood supply to an organ and it's the only blood supply, that organ is going to die and you're going to die. But the liver, subhanAllah, has two blood supplies. When somebody has a cancer in the liver, most of the blood supply to the cancers in the liver comes from the hepatic artery. So you block the hepatic artery. You still have blood supply to the liver from the portal vein. So blocking it will kill the cancer cells and leaves hopefully the normal tissues. This is common. It's not curative, but it's a treatment definitely. So this is what we call TACE, transarterial chemoembolization, or TARE, transarterial radioembolization, where you give Y90, yttrium-90. It's a radioisotope, and you give it injected into the hepatic artery and sort of kills the cells. It's in conjunction with other treatments or other modalities for liver cancers or for cancers that have spread to the liver. And we could do it in certain other areas to an extent, basically.
And it has good outcome.
It does have good outcomes because especially in liver cancer. Liver cancer, when you have liver cancer, usually patients don't live more than a year, 10, 12 months, 14 months. But with the new modalities, whether it's TACE or TARE or even immunotherapy now, or what we call tyrosine kinase inhibitors, these patients could live 2, 3, 4 years. It's not a cure, but living a few months without any treatment to maybe 3, 4 years, أكيد it's a big difference.
طيب آخر سؤال خالص، الستيم سيلز، في ناس بياخدوا الستيم سيلز من الامبلايكال كورد بتاع البيبي وبيعينوها، هل في أي يوسج ميديكال يوسج في treatment of cancer for this؟
Okay, so now we're going into a different modality altogether. So this is what we call stem cell, or what we used to call in the past bone marrow transplantation. So a bone marrow transplant, or now what we call stem cell transplant, could be either taken from another person, or from the same person, or from placental stem cells. If somebody has a leukemia, an acute leukemia, or high-grade lymphomas, the treatment's usually chemotherapy followed by either what we call autologous transplant, meaning your own. You give chemo, high doses, you kill everything inside, and then you give cytokines, and then you give back your own stem cells. This is autologous. Or you take something called allogeneic, which is a matched donor, hopefully a sibling, a brother, a sister, a father, a mother, a cousin. This is allogeneic. This is from somebody else. And these are usually for leukemias and lymphomas and perhaps myeloma, more so autologous for myeloma. Stem cells from the placental stem cells are used, but very little, because the harvesting of the stem cells from the placenta are very minuscule as compared to what you get from your own or somebody else. You need a lot of them. And they're not as popular now. You cannot harvest them in that great number, and you cannot expand on them. So it's very limited. But should I be harvesting placental stem cells from the placenta for I'm not a believer in it, to be honest with you. I don't think so.
Okay. Thank you, Doctor. I'm done.